Call the member for Mornington.
Thank you, Acting Speaker. Acting Speaker, I rise to speak on the Voluntary Assisted Dying Amendment Bill 2025. Firstly, this bill is not about whether voluntary assisted dying should be allowed for or not, but it is about the parameters under which voluntary assisted dying operates here in Victoria. First, I want to note that I've received many emails and contacts from residents of the Mornington electorate, and I do note a number of residents from the Mornington electorate are here now, and from across Victoria, including university students, and I do note that some students from Deakin University are here now as well, so I'd welcome them as well. Many of these people have written to me or spoken to me who are passionately for or against this bill. Most people who've contacted me are well-intentioned on all sides and want the best for our community, loved ones and so forth. So I do want to acknowledge the many members of our community who have contacted me with strong views either way. In my view, after listening to the many various views put to me, I cannot, though in good faith, support this bill as presented, particularly when it comes to clauses around conscientious objection from registered health practitioners, the potential expanded risk for elder abuse or abuse of authority, and in terms of timeframes, the fact that things change. Sometimes someone can be given 6 to 12 months to live and go on to live 10 years. Sometimes cures or treatments are found, and so forth. In my view, this bill relaxes the guardrails that Parliament deliberately put in place a number of years ago to protect vulnerable people, respect pluralism in healthcare, and maintain public trust. In all three tests, this bill, Acting Speaker, is problematic. And in contrast, we should be doing a lot more around palliative care, with funding, support and more. Organisations like Peninsula Home Hospice, who had their annual AGM just yesterday, are exemplary in terms of the services and expertise that they offer. And so I was honoured to have worked with them a number of years ago to secure over $500,000 for their new building fit-out, which has given them a very strong base to work on. Such services like this should be given much more support and funding. On the substance of the bill, the first key point I wish to address relates to patient safeguards, particularly when it comes to practitioner-initiated discussions in Clause 7. Under current safeguards, a patient must raise voluntary assisted dying first, something which can safeguard against subtle pressure in moments of shock, grief or dependency. The amendments in this bill permit health practitioner-initiated discussions across a wide range of professions, many without specialist end-of-life training. The risk is that this does not, to the same extent, prioritise treatment or palliative care options and amplifies potential bedside power imbalance. This is especially the case with those susceptible to elder abuse. In terms of international experience, in jurisdictions collecting data about end-of-life concerns, people commonly report loss of autonomy, loss of dignity, reduced participation and feeling like a burden, making them acutely sensitive to clinician and or family signals. One example is the Oregon Death with Dignity Act in the USA, and data shows that from 2018 to 2022, roughly 50+% of people choosing assisted dying cited being a burden on family, friends or caregivers as one of their end-of-life concerns. And in Canada, the Federal Veterans Affairs Department had to investigate cases where medically assisted dying was raised with veterans who had never asked for it. One Paralympian, Christine Gauthier, told a parliamentary inquiry she was offered it while simply requesting a home ramp. That single story shows how fragile the line can be between offering information and implying expectation. Now, I'm not implying that Victoria will go down that path, but there is a risk of a slippery slope without very strong parameters and protections in place. I want to also talk about the role of medicine. Medicine has been rooted in the idea that the physician's role is to heal, relieve suffering and accompany the dying. The ancient Hippocratic Oath from the 5th century BC binds the doctor to the work of healing and pledges fidelity to the patient. The expression medical ethics was coined in the early 19th century by Thomas Percival, defining physicians' duties. In the 20th century, the ethical vision of medicine was expanded by Edmund Pellegrino, who insisted the good of the patient is the telos of medicine. When we re-aim medicine at ending life, we don't just modify a statute, we redefine a vocation and we alter the message the law sends about which lives are worth the work of care. So 3 points I wish to raise. First, people have dignity independent of capacity. Human worth is not a function of what one can do today. The moral promise of medicine is presence without abandonment. That's why palliative care teams titrate opioids or in refractory suffering use proportionate sedation to give relief, albeit I do note in practice this can lead to death as things like morphine are upped and sustenance is reduced. But the line of intention is there to protect the vocation and the patient's trust. Second, autonomy is relational. End-of-life choices are at times formed in the currents of fear, family, finance and fatigue. In jurisdictions with assisted dying, people routinely cite the loss of autonomy, loss of dignity and feeling like a burden as reasons. This means even a subtle clinician suggestion is not neutral. It can land as permission to disappear. A law that shortens reflection, relaxes checks and lets clinicians raise death as an option risks turning context into consent.
Member for Mornington, I'll just ask you to take a seat for one moment. I'm required under sessional orders to interrupt business now.
Acting Speaker, I move that the sitting be continued.
The question is that the sitting be continued. All of those of opinion say aye. On the contrary, no. I think the ayes have it. We'll continue with the member for Mornington before we'll break for dinner.
Third, the law. What we legalise, we normalise. What we normalise, the vulnerable will hear. When we weaken safeguards and when we weaken guardrails, the state tacitly says, in these circumstances, death is a reasonable clinical outcome. We've seen how quickly signals matter. Media and case reviews have documented people seeking death because of social hardship, loneliness, health and insecurity, lack of supports, showing how context, not only disease, and not only situations where they have no chance of survival combined with suffering, can steer decisions. In Belgium, the boundary moved from adults to minors in a decade, illustrating how today's narrow exceptions can become tomorrow's starting point. Here in Victoria, regional uptake far outstrips population share, inviting the question whether people are getting sufficient care and respite or signals and speed. On eligibility expansion and compressed timelines, this bill standardises prognosis at 12 months, removes the third doctor check for neurodegenerative disease and shortens the reflection period from 9 to 12 days. The clinical reality is that prognosis beyond 6 months is more uncertain. Greater uncertainty should mean more checks, not fewer. The effect is then less time and fewer safeguards when risk of error or coercion is higher. On collapsing permits and blurring consent in clauses 32 to 42, this merges self-administration and practitioner administration into one permit that can be switched midstream. The problem is this blurs informed-specific consent, whereas separate permits equal clarity, not red tape. On interpreter exemptions in Clause 75, this allows exemptions from NAATI credentialed interpreters in life and death decisions. This contradicts multicultural best practice and invites misunderstanding or conflicts of interest, especially for cowed communities. On principle, if anything requires gold standard language safeguards, this does. The bottom line of safeguards is that if delays are the concern, we should better resource navigation and palliative care. We should not drain the guardrails designed to protect vulnerable people. Lastly, on conscientious objection. This bill compels registered health practitioners with a conscientious objection to participate by speech, to advise that another practitioner would be better placed, and to hand over government-approved information about voluntary assisted dying that could be changed over time. This is compelled facilitation and state-mandated speech, which is morally concerning. So in this context, Acting Speaker, under standing orders, I wish to advise the House of amendments to this bill that I have drafted, along with others, of course, and request that they be circulated.
The amendments will now be circulated.
Thank you. Thank you, Acting Speaker. In this context, I am moving an amendment to replace Clause 6 and make it clear in the substituted Clause 6 that registered health practitioners with a conscientious objection should not be forced to advise, refer or distribute official materials for voluntary assisted dying. This provides legal certainty. Acting per conscience is not a professional breach and must not attract disciplinary or employment detriment. This does not block access. Non-objectors remain free to advise or provide information. This is a mainstream medical belief supported by the World Medical Association, AMA, ANZ, SPM and many others. Lastly, I want to say that we should not be supporting this bill in its current form. I will, of course, be opposing this bill in its current form, and I hope that members will support this amendment.